Welcome, everybody. My name is Barbara Bonke, and I am an education coordinator in the Institute for Learning at ARUP Laboratories. I'm a medical technologist by background and a specialist in immunology. I'm actually going to be giving two presentations. The one today will be on immediate hypersensitivity. The next session will be on types 2, 3, and 4 hypersensitivity. To go along with this presentation today, you should have printed out the handouts that accompany the lecture. There's a lecture outline and a schematic or a diagram that you can follow along with. One of the first things when we talk about hypersensitivities is the question, what actually is hypersensitivity? Hypersensitivity, by definition, is a heightened state of immune responsiveness. It's an exaggerated or inappropriate immune response which causes damage in the host. Note, these are the same kind of immune responses that you'd see in a healthy person. They're the same mechanisms that the body uses when it fights off bacteria, viruses, other foreign organisms. But it becomes a hypersensitivity when the end result of that immune response is damage to the host, damage to self. Traditionally, allergy meant the same thing as hypersensitivity. But recently, we recognize the term allergy to refer to a specific type of hypersensitivity, which is type 1 hypersensitivity. And it's more the type of hypersensitivity when you talk like hay fever, allergies, allergic rhinitis, those kinds of things. So today we're going to talk about type 1 hypersensitivities. Back in 1962, two guys with their last names of Gell and Coombs came up with a classification system of hypersensitivities. And they based those classifications on the different basic mechanisms of immune injury that were occurring. They called them types 1, 2, 3, and 4. Type 1 hypersensitivity, the one that we'll discuss today, is immediate hypersensitivity because it can start occurring within seconds of exposure to the allergen, also called anaphylactic hypersensitivity. Type 2 is antibody-dependent cytotoxic. Type 3 is immune complex hypersensitivity. Type 4 is a little bit different in that it is not antibody-mediated. It's called cell-mediated or delayed type hypersensitivity. Since we've come to know more about the immune system, these 4 classifications from Gell and Coombs have been modified somewhat. The 4 classifications are not completely separate from each other. Sometimes symptoms overlap. Sometimes they occur sequentially. But it's a lot easier to get them straight in your mind if you look at them as the 4 classifications. So type 1 hypersensitivity is called immediate. That's because reactions can begin within minutes of exposure to the antigen, which in this case we would call an allergen. And like I mentioned earlier, it includes hay fever, asthma, hives, and also anaphylactic shock is a type of type 1 hypersensitivity. The reactions are dependent upon the triggering of IgE sensitized mast cells and basophils, and then the release of the resulting inflammatory granules that come out from the mast cells and basophils. So we have to understand what IgE is. You've studied the different kinds of antibodies, the different classifications. What do you remember about IgE? Anything? Does anybody remember anything about IgE? Is it a monomer, a dimer, or a pentamer? It's a monomer. It looks a lot like IgG. So it's a monomer, and you'll see it's got the same basic Y structure as you'd see in an IgG molecule. The heavy chains in an IgE are epsilon, and the light chains could be either kappa or lambda. IgE does not cross the placenta, so if a mother has IgE antibodies, they're not going to cross to the fetus. IgE does not activate complement. It does not cause agglutination. It does not act as an opsonin. And it's found in only trace amounts in the human blood, in serum or plasma. Only 0.004% of the serum immunoglobulin is IgE class. IgE in the body is more in the body tissues. It's found attached to basophils in the blood and mast cells throughout the body, in the bronchial areas, around the GI tract, in the skin and connective tissues, in the respiratory mucosa, and areas like that. Your overall scheme of type 1 hypersensitivity is seen on the diagram. And I'm going to talk about the 3 phases of type 1 hypersensitivity. We'll go into each of those in detail. The first phase of type 1 hypersensitivity is called the sensitization phase. This is the primary response when a person is first exposed to an antigen or the allergen. In most cases, it's a small protein. What happens is the antigen-presenting cells process and present that allergen to the lymphocytes, the B cells and the T cells. T cells will provide help to the B cells to help them produce antibodies. Especially the T2 helper cells are involved, and they will produce an interleukin called interleukin-4, which specifically helps the B cells make IgE type antibody. There's a genetic tendency for an individual to do this. The IgE then is quickly, it goes into the bloodstream, it goes through the tissue, and attached tightly to the mast cells and the basophils throughout the body. The IgE half-life on mast cells and basophils is about 10 days, where in the bloodstream, floating free, it would just be a couple of days. So now your mast cells and basophils are called sensitized because they have IgE molecules on them that have been developed as the antigen-presenting cells having seen the allergen. So you've got mast cells and basophils now sitting around that just have IgEs attached to them. The second phase of type 1 hypersensitivity is the activation phase. This is on second exposure to the allergen. The IgE molecules, if they're close together on the mast cells, the antigen can cross-link them, and this triggers changes in the cell membrane of the mast cell. There is a calcium influx that goes into the cell, and there is a triggering for degranulation of the mast cell. So any of the granules that have been contained inside the cell now get released out into the environment. These granules are called mediators of type 1 hypersensitivity. The third phase is called the effector phase. This is when the mediators travel throughout the tissue and the bloodstream, and they reach their effector sites and they attach to receptors throughout the body. And those receptors could be in the bronchioles, they could be in the blood vessels, could be in smooth muscle, could be in your skin. And the symptoms of asthma, allergies, hay fever, anaphylaxis are what now occurs. So when those mediators go out and they reach their receptors throughout the body, that's when you get the symptoms of hypersensitivity. Preformed mediators are those that are immediately available in the cell membrane of the mast cell or basophil. It takes just seconds for these to be released after those IgE antibodies have become cross-linked. Histamine is probably the most important one. Cells that have receptors for histamine will respond within just a few seconds, and the response could last maybe 10 to 30 minutes or so. Histamine causes a whole group of symptoms to occur. Smooth muscle contraction in the bronchioles and the blood vessels and the intestines. So you would see airflow obstruction, you would see cramps, you would see the stomach problems that you would get when someone says, I have an allergy to that kind of food. You'll see increased capillary permeability caused by the histamine receptors in the bloodstream. This causes fluid to be able to be released from your capillaries into the tissue. And you can get mediators out into the tissue. You can get edema. You can get swelling because of that. Histamine also causes increased mucus production. Watery eyes, runny nose, the symptoms like that. And then you'd also see local erythema or redness. A second preformed mediator is eosinophil chemotactic factor of anaphylaxis, or ECF-A. It attracts eosinophils to the area. Eosinophils are white blood cells that are really important in fighting parasitic worm infections. The eosinophils, in turn, can release granules which dampen the effects of histamine and other granules. So they can cause a downregulation of this type 1 hypersensitivity. Neutrophil chemotactic factor attracts neutrophils to the area. These are other white blood cells that fight off infection. And proteolytic enzymes such as tryptase and chymase, which could help destroy the allergen. Newly synthesized mediators develop sometime after the initial event, and they prolong the hypersensitivity consequences to 6 to 8 hours after initial exposure to the allergen. And they develop from the cell membrane lipids of the basophils and the mast cells. So some examples of these are prostaglandins, which mimic the effects of histamine. Leukotrienes, an important one here is called slow-reacting substance of anaphylaxis, which is very potent. It's 100 times stronger than histamine. And platelet activating factor, which causes platelet aggregation, promotes inflammation, vasodilation, and production of rapid shock syndrome. Some of the clinical events that you would see in a type 1 hypersensitivity. Atopy is one that we hear about. Atopy is a predisposition towards developing allergies or type 1 hypersensitivities. Atopy is a state of predisposition towards developing allergies such as hay fever, allergy to pollens, animals, dust mites, some types of asthma. About 10% of the population has atopy. This predisposition is inherited. A child of one atopic parent has a 50% chance of developing allergies. And if both of your parents are atopic, there's a 75% chance that the child will also develop allergies. Note, those allergies may not be to the exact same things. So if your parent has an allergy to sagebrush or strawberries, it doesn't necessarily mean you'll have those same allergies, but it shows that you're going to have a tendency to develop allergies. Asthma is when allergic particles reach the lower respiratory tract in your system. And so instead of hay fever, watery eyes, runny nose, you get the airflow obstruction and difficulty breathing because of bronchial muscle contraction, mucus in the lungs, and trapped air. A common problem to an inhaled allergen in an atopic individual is allergic rhinitis, which is the runny nose. And we see it a lot as hay fever here. To go along with the runny nose, there are watery eyes, nasal stuffiness. The symptoms of allergic rhinitis are annoying at best, but they can lead to serious complications like ear infections, sinusitis, and other conditions like that. So just a word about inheritance of allergies. There are several theories as to how atopy is inherited. And one of those theories says that you have a tendency to overproduce IgE antibodies. The tendency may be inherited as a recessive trait in some individuals. Perhaps there's an HLA-linked tendency. It's looking more and like certain HLA types in individuals are more likely to make strong affinity receptors on your basophils and your mast cells. So if you've inherited that tendency to really strongly grab onto IgE molecules, you're going to be more likely to develop allergies. Another factor may be a tendency to produce low IgA antibodies. IgA antibodies are the class that you would see in your secretions. And if you have fewer IgA antibodies, that allows allergens to get into your system and get exposed to those sensitized mast cells and basophils. So if you don't have the immediate line of defense, then you're more likely to develop an IgA reaction. Also, decreased T suppressor cells. The control of producing IgE antibodies is actually held under suppression by the T suppressor cells. So if you don't have as many of those, your cells are more likely to continue producing the IgE. So let's talk a little bit about food allergies. This happens when the allergen is ingested. Some of the most common food allergies involve cow's milk, peanuts, and eggs, certain shellfish, and there are several things that can cause allergies, food allergies. If the symptoms are just occurring in the digestive tract, the person might experience cramps, diarrhea, vomiting, those kinds of things. However, the mediators can also cause a change in stomach permeability, and the allergen can go through the stomach and small intestines into the body. And when those allergens now get into your bloodstream, you might see hives or eczema occurring because of the food that was consumed. Or in the worst case scenario, you'd see anaphylactic shock. And that's when the allergen goes throughout the body. The localized skin reaction is called urticaria or hives. Those are the terms that we're familiar with. In the lab, we often call it the wheal and flare reaction. And it's the large red bump or large red bumps that you would see in an allergy. Anaphylaxis is the most severe kind of allergic reaction that you can see. It's a systemic reaction when mast cells throughout the body are triggered, and there's a massive release of histamine and other mediators. The allergen is usually ingested or it gets directly into the bloodstream. Common culprits here could be bee venom, a drug like penicillin, and foods such as nuts, seafood, latex, things like that. The vascular permeability throughout the whole body is affected. So the symptoms may start as hives or cramps, but they can proceed to shock or death. As the vessels dilate, fluids leave the bloodstream, tissue edema occurs, blood flow slows, blood pressure drops, the bronchioles become constricted. Often a person who is having an anaphylactic reaction, their reaction is to grab their neck because they are unable to get enough air because of the swelling. And a person in anaphylactic shock can actually die of drowning from the fluids that are accumulating in his lungs. So it's life-threatening. So how do we diagnose type 1 hypersensitivities? Well, first of all, we do need to establish that IgE mechanisms are the cause of the symptoms. And we need to find out what the allergen is, what the trigger is. So we look at the clinical picture of the patient. We look at the family history. We look, is there a seasonal incidence to the allergic reaction? Blood work performed on the patient may show an increased serum level of IgE and eosinophilia, high levels of eosinophils, but not always. Okay, so the clinical picture. In vivo skin tests, you've probably heard of those. Some of you may have actually had a skin test. They're called a prick test or another kind of skin test. They can be done on your arm or on your back. What happens in those testing is there's actually a mini allergic reaction that is trying to be produced on your body. The clinician will inject tiny amounts of various kinds of allergens into your skin and then wait and see if an allergic reaction occurs in your skin. The mini allergic reaction will occur within 15 minutes of having the exposure. It's relatively simple to do, relatively inexpensive to do, but certainly not a desirable thing to do. If any of you have ever had an allergy skin prick test, you can attest to the fact that it's not very pleasant. But it is a very good way to diagnose what a person's allergic to. Diagnosis of type 1 hypersensitivities is also done by measuring IgE levels in the bloodstream. We can measure total IgE level or allergen-specific IgE levels. The total IgE level has traditionally been called the RIST, or the radioimmunosorbent test. And traditionally, the allergen-specific IgE testing has been called RAST, or radioallergosorbent testing. Now we don't use radioactivity as a laboratory technology much anymore. So both of these testing are done by enzyme immunoassays or FEIA, fluorescent enzyme immunoassays, or by chemiluminescent assays. But the traditional terms still stick. Therapy for type 1 hypersensitivities, number 1, avoidance. Stay away from or don't eat the offending antigen. It's a whole lot easier for foods to avoid foods. If you're allergic to sagebrush, I would say don't breathe. Yeah. Or don't live in an area where sagebrush is common. If you're allergic to cats, probably it wouldn't be a good idea to have cats as a pet. But sometimes a person is unable to avoid the things that they have allergies to. In this case, there is a therapy that's called hyposensitization. And what you do is you give the patient a series of shots or injections with tiny amounts of the allergen, the antigen. And You give increasing doses to the patient, and they build a sort of tolerance towards the allergen. The goal here is to help the patient develop high levels of IgG-type antibody so that if the patient is exposed to the allergen, their IgEs will grab on and take care of the allergen before they can get to the sensitized mast cells or basophils. This has been pretty effective for like bee stings and certain inhaled allergies. Also, drugs and medications can be used to treat allergy symptoms. The most important one, or the most common one, is antihistamines. Antihistamines compete with histamine for the receptors in the tissue. So they block the effects of histamine when it is produced. Often works in symptoms of hay fever. A problem with antihistamines is, especially the first generation ones, they also cause drowsiness in the patient. So the same mechanisms that were blocking the histamine were causing drowsiness. There are now better antihistamines that don't cause the drowsiness problems. Epinephrine or adrenaline. Epinephrine is the life-saving therapy if a person has gone into anaphylactic shock. It's the EpiPen that you hear about, that some people who are really allergic to peanuts or bee stings carry around with them. It relaxes smooth muscle and it decreases capillary permeability. Some others are bronchodilators such as theophylline, which are useful in asthma, steroid hormones, which reduce inflammation, and recombinant IgE antibody therapy. So, a summary for type 1 hypersensitivity. We've talked about immediate hypersensitivity. Type 1 is called immediate because it can occur within seconds or minutes after exposure to the allergen, and the culprit antibody is IgE. There are 3 phases to type 1 hypersensitivity. Sensitization, which is primary exposure to the allergen. Activation, when the allergen is encountered a second time and the mast cells and basophils are triggered to release their granules. The effector phase, when the histamine and other mediators go out into the tissue and cause their responses. The mediators are preformed or newly synthesized out of the mast cells and basophils. Most important one, histamine, but you'll also see other mediators that attract eosinophils, platelets, and other white blood cells. Some of the common clinical events that you would see are atopy, food allergies, and in a serious case, anaphylaxis. Diagnosis of type 1 hypersensitivity is to find out, first of all, does the patient have an allergy? What's the clinical picture? Do they have a high level of IgE antibodies by the wrist test? Do they have high levels of specific IgE antibodies against specific allergens, which is called the RAST test? Therapies for type 1 hypersensitivity can include avoidance of the allergen, hyposensitization injections, and various medications. A question that's been asked is, since IgE is such a nuisance antibody, why in the world, in the evolutionary process of human beings, did people develop high levels of IgE? And one of the theories is, or one of the correlations that you find is, in areas where there are lots of parasitic worm infections, there are very few allergies. It's only in civilized countries where we have cleared out the various kinds of parasites that we are troubled by hay fever and asthma, because in parasitic communities, all of that IgE is on the mast cells fighting off the schistosomes and all of the other worms. So I think it's just kind of interesting that we're being plagued by an evolutionary process that helps us fight parasitic worm infections. Thank you for your attention today. The second lecture in this series will be on types 2, 3, and 4 hypersensitivities, and you will find a second lecture outline and handouts to go along with that presentation. Again, thank you.